This Week in Parasitism is brought to you by the American Society for Microbiology at microbeworld.org/TWiP. This Week in Parasitism, episode number 11. Hi, everybody. It's Vincent Racaniello, and I'm with Professor Dickson Despommier.
Hey, Vince.
Dick, how you doing?
I'm doing well.
Welcome back from Mexico.
Thank you.
Was the fishing good?
Fishing was fabulous.
Did you eat some of the fish you caught?
We did not, but we did eat a fish that we didn't catch, but rather was spearfished.
Wow.
It's called a hog fish.
You didn't spearfish it, did you?
No, I did not. But interesting place that we were at. We were a place, I'll spell it first and I'll try to pronounce it for you. X-C-A-L-A-K.
X-C-A-L-A-K. Can't
Pronounced
pronounce it.
Schlack.
Schlack?
Right.
I get a lot of schlack around here.
Ixchlock. It's about 10 miles from the Belize border. It's on the Yucatan Peninsula all the way down to the bottom. And there's an enormous bay behind Ixchlock.
Yes, I remember looking at it on the map.
That's where the guides took us to go fishing.
Oh, you went in the bay, not in
not in the ocean.
The ocean is called the Gulf of Mexico, right?
This is correct. So we caught bonefish, and I hooked a tarpon, but I didn't land it. I saw a guy catch a 16-pound permit, which is a wonderful fish to try to catch. We saw a lot of Jack Crevalle. But the fish that we had that was the most delicious fish I've ever eaten is called a hog fish, and it's a reef fish that actually eats the 2-cell layers off of coral, which is what coral is composed of, just 2 cells. But in doing so, they have these big teeth that they scrape the coral with to get the cells off, right? In other words, a coral is only 2 cells thick, and your cornea is only 2 cells thick. So you have something in common with coral. At any rate, these fish actually generate the quotes-unquote sand on the beach. The sand on the beach turns out to be pure calcium carbonate, and the parrotfish and the hogfish defecate the coral, the inert portion of coral, and digest these little cell layers, and that's how they feed. And then the coral regenerates and grows back over that.
Symbiosis?
It's very nicely balanced.
Those commensal.
Fish...
No.
No.
But the coral doesn't get anything out of it, does it?
I think it gets stimulated to renew itself. It's like mowing the grass. You know, you mow the grass grows stronger. You cut your beard, it grows faster back, right? At any rate, the hogfish turns out to be a delicious fish. So we had 2 of them on separate nights, and on one night they were closed, this restaurant. And this is, I don't know why anybody would be interested to hear this, but we were. The restaurant was so narrowly focused in terms of its clientele that you could show up a day before and put an order in, and they would tell the spear fishermen the next day in the morning to go out and get your fish.
Ah, that's great. How fresh is that?
It was fabulous.
That's great.
It was just fabulous. So we had hogfish twice, and it was just wonderful prepared fish.
Good to have you back.
Good to be back. So I came back to find an issue of Science Magazine laying on my table at home that contains an entire section devoted to tuberculosis and malaria. Well, we're not going to discuss tuberculosis today, but we will certainly continue our discussion on malaria. And the reason why it's always in the news is because we haven't found a drug that will eliminate it from humans, nor have we found an insecticide that we can kill off all the mosquitoes that carry it with, nor have we developed a vaccine that we can prevent it with. So for that reason, malaria is ever present. And that's why it's such an important topic.
Right.
And it kills a lot of people.
And
but remember, we said that the mortality rate for this is less than 1%. We're being invaded. Oh, this is Fleet Week, and out the window, what are we looking at?
It's an airplane with its propellers tilted up.
No, I know the name of that airplane. It's a marine airplane. It's called the Osprey.
Okay.
An Osprey just flew by.
So they have a lot of planes, military planes and boats sailing up and down the Hudson.
So we just saw an Osprey go by.
So are we going to continue malaria today?
We are. We certainly are.
What aspect?
Well, we're going to talk a little bit about the epidemiology, and then
good.
we're going to talk about the clinical aspects, and then we're going to talk about how to prevent it, and then we're going to talk about maybe how to cure it.
By the way, microbeworld.org which hosts us, TWiP, they have a podcast called Microbe World. Let's see if we can find it. Yes, here it is. Let's see if we can find an archive, because there was a good one I want to show you.
Okay.
And no, it's Meet the Scientist. I'm sorry, folks. I'm just very bad here. I'm looking for Microbe World's Meet the Scientist podcast, which is right here with Carl Zimmer.
Oh yeah, Carl. I know
Carl is a science writer for the New York Times.
Carl's a good man.
And here we had a few weeks ago Erwin Sherman.
Know him very well too.
The Quest for a Malaria Vaccine: The First 100 Years.
Yeah, Erwin's good friend.
So I listened to this. He's very, he loves to talk.
He does.
At the end, Carl thanked him. He says, I love to talk about malaria. Anyway, I encourage everyone to go see this. It's at microbeworld.org. Meet the Scientist number 49.
Erwin Sherman was a postdoc with Bill Traeger at Rockefeller.
Okay, so he actually also recounted the story of the growing the malaria in culture that you had talked about. Yeah,
under anaerobic conditions. That's right. Or microaerophilic conditions.
He talked about it in a little detail. There's a picture of him.
Terrific. Yeah,
he's got a safari hat on.
Erwin's a big user of our textbook.
See that?
Yep. No, Erwin's a good man.
Oh, yeah?
Yep.
Well, let's get him on sometime.
Okay.
We'll have to have a little space so we don't compete with Meet the Scientist. But 12 Diseases That Changed Our World. That's what he's written. Yeah. And the Power of Plagues.
Yep.
Okay. Sorry for that diversion. Nice issue of Science. Yes, this is the May 14th, 2010 issue.
Yep.
Tuberculosis and Malaria.
Right.
And you've said it's very important because we don't have drugs, vaccines, or ability to get rid of mosquitoes. We have some drugs, though.
We do. And they're partially effective, and we have some preventatives, like mosquito netting, that's impregnated with insecticides. Right. Or they always used to say at our tropical medicine meetings that the best cure for a tropical disease is winter.
Right. It doesn't happen in the tropics, does it?
Well, something happens in the tropics.
It doesn't get cold like
No,
here.
but they're dry seasons.
Yeah.
So if you have a dry season, it reduces the incidence of malaria, but it doesn't eliminate it.
So today you're going to tell us a little bit of epidemiology and disease.
Yep.
All right, less than 1% mortality.
Right, and yet over 3 million people a year die from it. So that tells you how many people actually have it.
One thing that I was very impressed by, I just finished reading a book, Inside the Outbreak, A History of the Epidemic Intelligence Service of the CDC. Mm-hmm. And they sent a lot of agents to countries with malaria.
Right.
And what struck me is that they have no windows. The water quality is horrible.
That's right.
There's just no money.
They were at
and
risk.
It's very hard for these people to avoid being infected.
No question.
We take it for granted. We close the windows.
I know.
We have pure water.
You're right.
But they don't.
One of the worst places to catch malaria is in the hospital because someone's been admitted with malaria.
The mosquito will
so
bite
now they
them
become a
and
center
bite
for the dissemination of malaria in many places.
Now, your book, Parasitic Diseases, doesn't have anything about epidemiology. And
sure it does.
It does? Okay.
Sure.
So I'll open it up here.
In fact, it has a lot on that. It has a whole chapter on mode of action of drugs, which was written by Dr. Charles Knersch, who is an expert on malaria.
Is it separate from the life cycle?
Yep.
Oh, and what about epidemiology?
That's covered in the
basic,
the disease aspect. And
would it be in this chapter?
Following the clinical aspect. Yeah, sure. It's all there.
All right, so we talked about the life cycle last time.
We did.
So...
and how it's transmitted, and we talked about the mosquito role in all of this.
Exactly, all that stuff.
We've never talked about actually what it's like to have malaria.
All right. Do you know for a fact what it's like?
Secondhand, I've never had malaria myself. I've been in areas, though, where I could have caught it. I did not, but I could have caught it. So I've had to take prophylaxis.
If you were going to go to an endemic area...
We'll get to that. That's under prevention.
I think the key, Dickson, is not to travel. Just stay home.
Tuck your head between your legs, or into the sand is even better. That way you can never see. You got an
internet. You could see the world by your computer screen.
Absolutely.
You could even virtually fish. My son has a fishing application for the iPad. He catches fish. Graphics are beautiful.
Yeah, and you don't gain any weight by eating them either.
You become a breath breatharian.
A breatharian.
No need anything. You won't get sick. It'll waste away, right? All right, take it away, Dickson.
Okay, so the infection in humans begins with the female Anopheline mosquito that's infected.
Yeah, with this
taking a second blood meal. Now, blood meal, I'm referring to it as a blood meal because she doesn't really bite you. All right, these are not biting mouth parts. These are sucking mouth parts.
Well, they have to put the thing in, right?
The hypostyle.
Hypostyle into your
skin. It's a stylet that's in the shape of a hypodermic needle.
She goes to a capillary, which we said she can sense the presence of.
She can.
And then draw some blood, and while she's regurgitating, the sporozoites go in you.
I'm reading this book, by the way, which I've already mentioned on this show, called From Archimedes to Hawking. And it's a book written by a guy by the name of...
From Groucho Marx to Despommier. That's my book.
Well, Marx will get a lot of laughs, and Despommier will get them too, but not for the same reason. This book, by the way, had something related to malaria, although it's not directly related, and that is the fact that there was a scientist who studied fluid dynamics, and there's a law of fluid dynamics. Now, Vince, I'll give you the quiz. You have two choices, straw number 1 or straw number 2. Straw number 2 is twice the diameter of straw number 1. How much more fluid, sucking at the same pressure, do you think you'll suck up through straw number 2 than through straw number 1? Is it twice as much, 4 times as much, or 16 times as much? It's a trick question.
Well, because it's the volume of a cylinder.
Yes.
And so it's not just 2 times.
No.
The volume of a cylinder is pi times the radius times the height.
Look at him. This is good.
The circle is pi times the radius, and then you got to multiply it times the height. So.
That's right. So given an equal pressure on both ends of this capillary, right? Mm-hmm. And if the capillary dilates, get it?
Yes.
To increase the diameter by 2 times, which this mosquito can do.
Ah, really?
She can suck up 16 times more blood in the same length of time using the same pressure. Isn't that amazing?
No, she's adapted that way. She's evolved to have something that dilates it. Yeah.
And that's why angioplasty actually works.
Angioplasty. Yeah, what is angioplasty?
Well, they insert a catheter into your cephalic vein.
Yes.
And it goes into your heart, and then they direct it into the coronary arteries that are plugged up.
When they're occluded.
Mm-hmm. When they're partially occluded.
By atherosclerosis.
Not totally. Yeah, and what they do is they inflate a balloon. And the balloon expands and presses the cholesterol plaque and enlarges the artery by 2 times the volume. What does that do?
16 times.
It increases the blood flow by 2.
Balloon angioplasty. But you know, Dickson...
Isn't that amazing? And then it just plugs up again, too, because you don't change your diet.
Can you take that off so it doesn't keep hitting?
Sure. My watch. They were referring to my watch. Keep going.
It turns out that... You damage... So atherosclerosis is an inflammatory disease.
It is.
You have damage to the artery, then you have accumulation of cells. And
that's true.
So when you do this angioplasty, you have a temporary relief.
That's right.
Because it actually does damage and it perpetuates the atherosclerosis. Exactly. We used to think it was just cholesterol depositing, but it's actually an inflammatory disease.
There's a whole bunch of things. It could be due to chlamydia, by the way. That's another take on this. But the point is, back to the mosquito.
Do we know the compound that the mosquito uses to dilate the capillary?
It's a protein of some sort, and she's got a pharmacopoeia in her salivary glands that she uses to vasodilate and to anesthetize and to increase blood flow and heat detection systems. A whole bunch of stuff. There's this guy by the name of, I'm going to block on his name, unfortunately. Well, Tony James at UC Davis.
And
UC San Diego.
And the Shondells. Tony James and the Shondells.
Tony James is now a member of the National Academy of Sciences. He's one of our few parasitologists that's actually admitted into that august body of scientists for studying all of the things to do with mosquitoes that help it transmit this
amazing,
infection.
For a little thing like a mosquito to have so many agents.
Tell me about it.
Well, these have evolved in order to make it do what it needs to do.
They take advantage of a vector, and this is the vector.
Yeah.
Okay, so the mosquito now has the sporozoite stage in its salivary glands and also in its hypostyle. When it takes a blood meal, It injects all of these pharmacologically active compounds to set it up. Okay? And we know the reaction to this too because we develop an allergic response to them, but it's delayed. After the mosquito withdraws her mouth parts and she flies off, then it starts to itch, right? And this may actually aid and abet the parasites in moving from that little area into the blood. The point is, though, that the sporozoites are now in your blood, and they have to find their way into your liver, which they do. Remember we talked about the sinusoidal receptors and all this.
Everything passes through the liver.
Right. So if you're bitten on day 1, I think you should ask me, how soon afterwards do you get sick?
If you're bitten on day 1, on which day do you show the first symptoms that you would say, hey, I don't feel right?
That's right.
Fever, aches, vomitus,
right.
Whatever.
Right. So the first thing to consider is how long does it take the parasite to develop to the stages that infect red blood cells? And that's called the pre-patent period.
Right, we have to get into the liver cell first, right?
That's right. It goes into the hepatocyte. It develops into the cryptozoites. Yeah. Cryptozoites develop. They burst out into the blood.
Correct.
They then can invade red cells, but they can't go back to the liver.
Right.
So once they're in the red cells, now that takes about, it depends on the species, okay, but from 9 to 12 days of just sitting in your hepatocytes, reproducing as cryptozoites first.
And you're fine at this point.
Absolutely fine.
You don't feel anything.
Nothing.
Is your body doing anything? Making an innate response?
Your body is sitting there saying, I feel fine, nothing's wrong.
And it's not responding in any way?
Nope.
I find that hard to believe.
It's cryptic. It's in your
Is that why
liver
it's called
cells.
Cryptozoite,
cryptozoite, right? So then it gets into the red cells.
Bursts out of the liver, gets into the red cells.
Now,
Still, you still don't feel anything.
Still fine? No, you're still fine.
9 to 12 days so far?
That's right.
Okay.
So that's almost like 2 weeks.
Yeah. You could be home and back in London.
Could. That's correct. Or New York or Paris or wherever else you go, right? I could have picked it up in Belize and still not known it. This trip, I could have picked it up.
Is there malaria in Belize?
Sure.
Really? I didn't know that.
There's malaria in Mexico, in Chiapas. Okay, not so much in the Yucatan. There are other things in the Yucatan you have to worry about, but not that.
Okay.
Okay, so the point is that once it's in your blood, it's now called the patent period.
Okay.
Why? Because you can detect it with a microscope. You can take a blood smear, you can stain it with some interesting stains like Giemsa or Wright's. You can look under oil. That's high magnification, right? About 1,000 times magnified. And underneath each oil field, you have about 200 red cells when they're all touching each other.
Of course, at this stage, you would have no reason to look in someone's blood.
None.
You have
Unless,
no symptoms.
of course, you were doing a survey.
Right. And you just chanced upon it.
Or you said, you know what? We forgot to take our anti-malarials while we traveled to Africa. I bet you some of us have malaria.
Sure.
How long has it been since we've been there? 2 weeks. We can start looking after second week. And then you look and you look and you look, and eventually, if you've got it, you'll find it.
All right.
But
So
it
we
takes
got
a lot of
it's
looking.
in our blood, but
But
we
you're
don't
still
feel
feeling
anything.
fine.
All right.
Now, it undergoes several replications, okay? So, replicative cycles. Now, this sounds like a virus.
It does.
It does. It's intracellular. The organisms are all clustered together inside the cytoplasm of the red cell. They're consuming hemoglobin. They're saving the heme portion as hemozoin. They're stacking it up with their stacking enzymes. The reproductive cycle of malaria varies with the species. The number of merozoites produced per red cell differs, not by much, but the rapidity in which it occurs.
Species being Falciparum, 5X ovale, and malariae.
That's correct, and occasionally Knowles eye.
All right.
So, I mean, Falciparum is the one everybody worries about because when it attaches to the precapillary beds of the body, it produces a tissue reaction on the other side of the capillary, or precapillary, I should say, which induces tumor necrosis factor. And tumor necrosis factor, as you know, produces nitric oxide. And nitric oxide is a narcoleptic substance, and it puts you to sleep. You go into a coma. This is why that particular brand of malaria is called cerebral malaria, not because it's a thinking person's malaria, but rather because it puts you to sleep. This has huge clinical implications because when you're asleep, it's hard to take a drug orally. So now you have to give it intravenously. you have very few choices.
Is this because this is occurring in your brain?
Yeah, and everywhere else too. But in your brain, of course, when you induce nitric oxide on the brain side, it puts you to sleep, right?
Now, is that the first symptom? No,
of course not. The first symptom of this infection, although you asked me whether I had had this myself or not, and I said, no, I haven't. I've heard so many anecdotal stories about malaria over the 38 years of being here, not only as a technician, but also as an instructor, that I can confidently say that the first sign and symptom of malaria in a person who's never had it before looks nothing like malaria. What I'd like to do for you is, instead of describing general characteristics, I want to give you a real case. And this is the case that I have used for a long time in my teaching here to illustrate how serious and sometimes tragic malaria can be. Most people, when they hear 3 million people die a year of anything, it's hard to imagine that number. It's easier to imagine 1 and then multiply times 3 million. So what I'm going to do now is to tell you about one case.
Before you do that?
Yes.
When do the symptoms appear? When the cryptozoites are multiplying in the red blood cells. You said
the merozoites.
The merozoites, sorry, there are a few cycles, but then
there are a few
after
cycles.
that.
There has to be many cycles in some cases.
So just a few will not give you symptoms.
No.
So,
and in fact, if it's vivax malaria, which is the lively malaria, but it doesn't adhere to the precapillary vessels, then you can go under multiple division cycles before you start to develop symptoms, largely related to the release of metabolic byproducts that are created by the parasite's metabolism, the waste product hemozoin, and the loss of oxygen carrying capacity of the red blood cells that decreases when you get rid of hemoglobin. So those three things together equals the classical signs and symptoms from malaria. Signs, do you know the difference, Vince, between a sign and a symptom?
A sign and a symptom?
Yeah, what's the difference?
A sign? I don't know, Dickson. I could give you all sorts of definitions, but you might as well just tell us.
Okay.
A sign is an indication that something is happening. A sign is like fever or
is fever
skin.
A sign or is that a symptom?
I guess it's a symptom. What's a sign? It's too tricky a question.
No. It's a simple
symptom
clinical...
is fever, blue skin, red eyes, bloodshot, diarrhea. Those are symptoms. No?
Not all of them. Not the ones you've just mentioned.
Right. Fever is a symptom.
You can't see a fever, so therefore it's not a sign.
Well, whatever you can't see?
Correct. If you can feel it but you can't see it, if the physician looks at you and says, "What's wrong with your left eye?"
Oh, I see.
That's a sign.
Because he can see it, he or she can see it, but a temperature he cannot see, but he or she could feel it.
But of course.
And he could read the thermometer. So it seems to be a bit arbitrary, Professor.
No. It's not arbitrary at all. A sign is something that I can just look at you at and say, you've got something wrong. A symptom, I have to ask you how you feel. How do you feel, Vince?
Great.
I knew that. So.
Okay.
And how do you look? You look fabulous.
Do you know what the lesson is here, Dickson? I should just take the literal meaning of the word sign. It's words on a piece of paper as a sign.
Don't look for deeper meanings.
Yeah, that was.
And when Charlemagne looked for a sign from heaven, what did he see? He saw a flaming sword in the sky, he said.
Baloney.
It could have and could not have happened. He was. It was what he was smoking at the time that actually induced that reaction, which was, of course, a symptom.
So what are we talking about here, a sign or a symptom?
Well, we're talking about both.
That's a nice name for this episode. Malaria, signs and symptoms.
Correct.
Don't you think?
I do. So one of the signs of malaria is shaking chills. Yeah. Shaking chills.
When does that start?
Well, it starts a long time after the division cycle of this parasite starts.
Shaking chills. So that would be one of the first symptoms, shaking chills.
And fever. Right?
All right.
It's called the paroxysm.
Is it a rapid onset of fever? No, it's been already 12 days.
That's right. That's
very rapid.
It occurs gradually. So I'm going to tell you...
Paroxysm?
Yeah, the paroxysms of malaria are chills, fever, followed by chills, fevers, followed by sweat.
All right, tell us your story.
Is both a sign and a symptom.
Chills and sweat.
That's right. So chills, fever, sweat. Chills, fever, sweat. Chills, fever, sweat. Chills.
Chill is a sign.
Yeah.
Sweat is a sign, but fever is a symptom.
That's correct. Vince, you got it now. You've got it. You're going to be a clinician.
I'm just a learner.
Your father was a clinician.
He was a clinician.
He knew the difference.
I am not going to be.
He never passed that knowledge on to his kids.
No, he was a quiet man.
Okay. So here's my story then. Well, that's actually not the first indication that you're sick from malaria, though. That's later on in the infection.
All right, what's the first indication?
If you've had it before,
I'm working on this.
It depends. No, you have to qualify it every time. You have to say, in a person who's never encountered malaria before,
that's fine. Let's do that.
Then here are the classical first indications that you might have something wrong with you that could go on to develop classical malaria.
All right, go ahead.
A backache.
All right.
And a headache.
Pretty nonspecific, Dickson.
Sounds like they often misdiagnose it as...
Those are symptoms.
They are.
They're not signs.
No, they're not. No, that's exactly correct.
Often misdiagnosed as...
They say flu-like symptoms.
Yeah.
Flu-like symptoms, which is it's a catch-all for nothing. You've got flu-like symptoms. What does that do for your diagnosis? Zip. Okay, so here's my story. And it's a sad story, unfortunately, but it illustrates what can happen with malaria, okay? It involves a 13-year-old girl who turned 13, who was a child of a broken family. Father and mother divorced when she was like 10, as I recall. And the father remarried. And the daughter would stay with both the mother and father, depending on what time of the year and what holidays and things like this. So her stepmother said to her, for your 13th birthday, and I don't want you to tell anybody this, I'm going to take you to Kenya. And we're going to see the animals. We'll see elephants, and we'll see hippopotamus, and we'll see crocodiles, and we'll see secretary birds, and we'll see Cory bustards, and we'll see monitor lizards, and we'll see... And her eyes just kept getting wider and wider with anticipation. Remember, I like to tell stories, right? But this is a true story. She says, whatever you do, don't tell your mother. In fact, don't tell anybody. This is just our secret. I'm giving you this for your 13th birthday. Okay. And she said, okay. So the next week they got on an airplane and they flew off to Nairobi and they went on safari for 2 weeks. And they came back and now it was her real birthday. And her birthday now was celebrated on Long Island with her real mother. Her biological mother, I should say. The other person was her real mother, too. So she went out and celebrated her birthday, and they stayed out in Long Island for about a week. And during that time, she began to feel poor. Her health deteriorated to the point where she was distracted, bothered. She couldn't sleep at night. She didn't describe her symptoms very well to anybody. But eventually, the second week that she was on Long Island, that's a month after starting her trip to Kenya, she developed a headache, fever. Her mother took her to the doctor. And the doctor suspected that this child had some infection of some sort. Didn't know what, right? And he prescribed, I think, palliative treatment, some anti-inflammatories, and maybe some aspirin or something like this.
Why didn't he take a history?
Because she wasn't that sick. So she went back.
Wouldn't you ask her where you've been in the last
No, because she wasn't, there was nothing to trigger that response yet. So she went home to Long Island, and 2 days later, she developed shaking chills, spiking fever, classic sweats. Her mother said, the medicine isn't working. He says, bring her back. She brought her back. And he says, tell me again what you found. I found her shaking in her bed sheets. Absolutely. She was terrible, terrible shaking chills. Then she developed a fever. And when the fever broke, she broke out in a huge amount of sweat. And then she felt great. But I think there's really something else wrong. He says, I think there is something else wrong. So he sat the girl down and he said, if I didn't know any better, I'd swear you had malaria. Have you been to a place that has malaria? Like South America or Central America even, or Southeast Asia or Africa? And the little girl looked up and she said, no, of course not. He says, well, gee, then I don't actually know what's wrong. She says, well, I feel fine now. So he says, well, if you start to feel badly again, he says, please come back. She says, you don't have to worry about that, doctor, because we're going back to our home in Englewood, New Jersey. So if she gets sick again, we'll probably bring her to Englewood Hospital, because I know the doctor's there. It's a true story, by the way. Okay. So sure enough, they drive back to Englewood, New Jersey from Long Island, which is about 125 miles. Next day goes by, she's fine. The next day goes by, she's fine. The next day goes by, and she's got shaking, chills, and fever, and sweats. Worse than it was on Long Island. Her mother now knows that there's something dramatically wrong. She brings her to Englewood Hospital. The little kid's almost unconscious at this point. And of course they do a complete workup, right? And lo and behold, on a blood smear, a differential blood smear, where they were just looking for the number of neutrophils and the number of lymphocytes and the number of monocytes and the number of basophils, the number of eosinophils, and the number of platelets, the number of reticulocytes. They saw a whole bunch of reticulocytes. This is very unusual. She's got a hemolytic process going on. She's making more red cells than she should be. And an alert technician spots the offending organism in a red cell. This is on a right stain. That's not so good to look at blood smears with for malaria, but they picked it up. A lot of our technicians here at Columbia come from the islands of Haiti, the Caribbean, and they're used to seeing malaria on blood smears, and they pick them up on routine blood smears because we have a big Hispanic population in New York City. And that's true for other cities as well. At any rate, this little girl was diagnosed with Plasmodium falciparum, the worst form of malaria. Now, this is a while back, in a time where drug resistance to malaria was just starting to emerge in Africa. Mm-hmm. It didn't start in Africa, by the way. It started in Southeast Asia during the Vietnam War, but we'll get back to that. Anyway, this little girl was obviously very sick. And lo and behold, she went into a coma. Tumor necrosis factor was induced, nitric oxide was produced, she went to sleep. Now she can no longer be given oral drug. In the meantime, they shipped her over here to Columbia Presbyterian Hospital, to Babies Hospital. It used to be known as Babies Hospital. It's now known as Women's and Children's Hospital. She was admitted as an emergency admit. She was unconscious. She was already diagnosed as having malaria. So what do you think they did, Vince?
Intravenous medication.
Yeah. And what kind of intravenous medication?
What year is this?
This was in the late 1980s.
I don't believe we had the artemisinin yet, right?
No, definitely not.
So
you had two choices.
Chloroquine?
That's not an intravenous
Quinone?
drug. Quinine is one. Quinine is one, but there's another one called quinidine. Okay, now they keep quinidine and quinine in the pharmacopoeia in a hospital. Quinidine is used to correct arrhythmias, believe it or not. Quinine, the parent drug for quinidine, when given intravenously, can sometimes induce them.
Arrhythmias.
Yes. But
so quinine would be taken orally normally for
correct.
malaria.
That's exactly correct. Along with something else. I mean, you'd probably give it with an antibiotic like tetracycline or clindamycin.
Well, of course, if they're awake, you can give them chloroquine too.
Yep.
Okay, but she's out.
But they even had resistant malaria in those days in Kenya, so that they probably would have opted for the quinine plus approach. Okay? But she's out. So they start her off with, well, quinine is still the parent drug, so they should do this, right? There was no literature on any side effect of quinine intravenous. None. Ooh, too bad. A fourth-year medical student who had spent some time in my laboratory was actually in the room. That's how I know what happened.
Ah, he told you the story.
He did. He did.
He knew the whole history.
His name was Einbinder, Dr. Einbinder. Julia Einbinder was his mother, and she was a good friend of mine. She was a technician here as well. I'm blocking on his name, but I'll just call him Dr. Einbinder. I think it was Michael. Anyway, Michael described what happened next, and they gave this little girl intravenous quinine, and they induced an arrhythmia. What do you do for an arrhythmia, Vince?
Shock?
You could do that.
Drugs?
What else? Cardiac massage.
Really?
Cardiac massage. Now, one of the big effects of malaria during the acute phase of clinical symptoms, as I'm describing now, is called splenomegaly.
Oh, boy.
Splenomegaly.
An enlarged spleen.
Correct.
In fact, we have a picture
We do.
in your book of a child.
We do. So
Why does this happen?
It happens because the spleen can sequester diseased red blood cells.
Mm-hmm.
You know why? Because they have a different charge on them. The parasite actually induces a different charge on the surface of the membrane of the red cell. And this spleen can actually cull off the part of the red cell that's diseased and clip off a little piece to send back out in the circulation to hopefully sequester more oxygen so the patient can at least have some advantage to this, right? It's an amazing organ, the spleen. But when it enlarges too fast, what do you think happens?
It ruptures.
It could.
Especially if you fell or were squished, as in CPR.
Exactly, Vince.
So they ruptured her spleen.
By giving her CPR.
Oh, my gosh. And she bled to death.
But at the same time, of course, she woke up.
Mm-hmm.
How did you guess that she bled to death?
Well, when your spleen ruptures, that's often what happens.
This is right, especially if you don't know that.
If you don't know, because
happening.
kids often fall and they will rupture their spleen, and
right.
an alert physician can tell because they're anemic, and they say,
right.
you have a ruptured spleen, let's get you right into surgery.
Yeah, and they take it out.
But you do have a little time.
You have a little time. But this ruptured, and they didn't realize what had happened.
They didn't realize it?
They did not know. They didn't realize what happened. So this little girl eventually woke up because the quinine did bring her back.
Right.
Long enough for her to look up and see her mother. And she was quoted as having said, "Mommy, please don't let me die." But of course, another hour later, and she died.
That was fast for a ruptured spleen, though.
No, they ruptured it like 3 hours or 4 hours earlier.
And they had no idea.
None, because she was asleep. She woke up just in time to die.
Yeah, I think there are signs of ruptured spleens that are obvious.
Well,
I can't second guess.
They were missed, I can tell you that. So
it's unfortunate.
This child became the poster child for switching from quinine, which induces arrhythmias, to quinidine, which cures them.
So at the time, did we have both?
No.
I see.
Oh, no, they didn't say that. No, that's wrong. We did have both, but we used them for different things. We didn't realize that quinidine was as effective against malaria as quinine because it's derived from quinine. So from that point on, the cabinet never had quinine in it. Pharmacopoeia only had quinidine.
You don't need quinine.
You don't need quinine.
Which was introduced to us by the Native Americans, right?
The Incas.
The Incas had it from the tree.
Correct. The cinchona.
Cinchona.
It comes from the bark.
Yeah, we talked about that 2 episodes ago.
That's right. So that's number one.
And orally, it doesn't induce arrhythmias.
No.
But intravenously, it will.
Quinine will. But quinidine...
Now, let me ask you a question, Dickson. So this was her biological mother or her stepmother?
Her biological mother.
Why didn't she give her anti-malarials before she went?
The stepmother didn't take them either.
Who took her?
The stepmother took her.
Oh, but neither took drugs.
No.
Why?
They didn't even consider it. Do you know how many people travel to malaria areas that don't have a clue as to what's going on?
Oh, I thought you would be told by someone to...
This was a surprise trip. This was all hush-hush.
Dickson.
Can you imagine the stepmother telling the child, and by the way, when you're home, make sure to take your anti-malarials, but don't let mommy see you? No. Neither one took their anti-malarials. The mother could have caught malaria too.
Well, let's see. If the girl had told the first physician on Long Island that she had gone to Kenya,
right,
would that have helped her at all?
I think it might have, because he could have said, this could be malaria, so they'll start to look for it. Now they'll look for it, and eventually they'll find it. The kid's still awake.
Quinine.
Give her chloroquine.
Chloroquine, yeah. This is very sad, Dickson.
It was exceptionally sad. Now, I must tell you that when I told that story the first time, I couldn't get through the story.
When was the first time you told it? In the 80s?
It was the year it happened.
Do you tell it to your classes?
Every year. Every year. I said,
I'll bet it's quiet as anything in that room.
The best lecture I ever gave, I thought, in my entire 38 years at Columbia University was the time that my PowerPoint presentation failed. And it was the malaria lecture.
Yes.
And I said, I don't need PowerPoint, so I'll use the blackboard. But first, let me tell you a story. And I told them that story, and I still couldn't get through the story without choking up.
Mm-hmm.
I actually cry every time I tell that story in front of
What's the story called?
1 times 3 million. If you want to know the big effect of malaria, you take this one case and multiply it times 3 million, and you've got 3 million sad stories. It's 1 times 3 million.
It's not a bad episode title either.
I think we should call it that.
I forgot the other one.
Doesn't matter. The point is that malaria is a very serious disease, but remember, it only has about a 1% mortality rate.
In her case...
But look who's dying from it.
Well, in her case, she didn't have to die if they hadn't given her CPR, right?
Yeah, every one of these cases is complicated.
Yeah, I see.
Every one of them.
Now, she was asleep because the parasites were in her brain?
No, not in the brain. They're in the precapillary venules.
All throughout the body.
Yeah,
and
they stick.
And the nitric oxide diffuses to your brain. And
on the other side, on the tissue side...
Oh, they're in the capillaries in the brain.
Yeah, not in the capillaries, in the precapillaries. But on the tissue side of the precapillaries, tumor necrosis factor is induced by the presence of the parasite.
Yeah, so in the brain area, though, right?
Yeah. So but all over your body this is going on. All over your body. But in the brain, of course, it puts you to sleep.
Now, does everyone develop cerebral symptoms? Depends on the parasite, right?
No. It depends on if you've ever had this before.
Because it is a first time.
If it's a first time, the answer is probably yes. But let me tell you another case then.
Wait, before you do, in the first infections, what's the fatality? Still 1%?
Always 1%.
Always, no matter how many times you've been infected.
Children are dying. Now, what's the age group of the children?
What are they dying of?
Dying of total collapse of their circulatory system.
Due to?
The release of all these byproducts from the parasites and the lack of red cells.
Okay.
When you get to a 2% parasitemia, which means that when you look underneath the oil field of a microscope and you see 200 red cells and you see 4 infected, you know what happens next? Sure you do, Vince.
8.
And then?
16.
And then?
32, 64.
And how many replication cycles is that? It's another week and a half and you're dead.
Dickson, the replication is destroying the red blood cells?
Correct. Yeah. You're losing your capacity to carry oxygen.
Faster than you can make them?
Absolutely. And
that's why you have erythrocytes in your blood?
Well, that's why you have reticulocytes.
Reticulocytes, sorry, yes.
Sure.
Yes. Mm-hmm.
It starts throwing out reticulocytes. That's why the spleen conserves every little piece of red cell. Even if it's a diseased red cell with parasites inside, it'll clip out the part of the membrane that's not affected. It's amazing. Mm-hmm. You know how you can tell which part is affected and which isn't? You take a red blood cell suspension with parasites in them, and you suspend them in iron filings. And the iron filings will coat the outside of the red cell where the membrane is affected by the parasite. And the little part that isn't, that's the part the spleen sees. Yeah. And it just culls it out and says, I'll save that part.
Amazing.
It's truly amazing.
So go ahead, tell your other story.
No, I don't have any more stories.
You just said I'm going to tell another story. You had something in mind. You forgot?
They're all stories. No, I think the big story is that 3 million deaths, those are 3 million unique different stories. All right, no. I know what I wanted to say. The age group that dies are children, but there's a specific age group of the children that die. If you're born in a malaria area, and your mother has had malaria many times, many times, her antibodies will actually transfer to the fetus and to the newborn. Now, you know something about that subject, right? So how long does it take for the antibody levels to drop to 50% of what they were at birth? The 50% mark is 6 months.
It's that long?
Yep.
Yeah. Okay.
6 months. By the time the antibody level drops to 6 months, half of what it was at birth, you are now susceptible to malaria. But you're only 6 months old. Your immune system isn't fully developed. So guess what? That's the most vulnerable age group, 6 months to 5 years. If you've had malaria, let's say you're 2 years old, 2-year-olds probably don't die from malaria much. They suffer, but they don't die. I didn't say that there are no permanent effects from this disease either. We've recently found out through lots of very careful clinical studies, mostly by a genius in this field called Nicholas White, Dr. Nicholas White. His appointment is at Maidal University in Thailand. But he's famous throughout the Southeast Asia area for his rapid diagnostic methodologies, for determining whether or not you've got acute malaria or not without the use of a specific parasite stain. He doesn't even have to see the parasites. You know how he tells whether you're acutely ill or not? He looks in the neutrophils for hemozoin. If he sees it in neutrophils, he doesn't have to look at the red cells. He says, you've got a huge amount of malaria.
You mentioned acute malaria.
I did.
As opposed to
chronic malaria. Adults develop chronic malaria that live in malaria areas because they've got partial immunity. So that from season to season to season to season, you catch malaria, but you don't suffer as much from it.
You always have the parasites in you?
Not always.
You're just reinfected.
You clear.
I see.
But it's not a permanent protective immunity.
In the virus world, that wouldn't be a chronic infection. In the virus world, the virus stays with you.
Right.
Forever. But you're not reinfected. You just keep it forever.
Understood.
But that's okay. You can have a different terminology.
Well, they call it, we have continuous transmission zones, we have intermittent transmission zones, and we have seasonal transmission zones. And the clinical pattern in each is different in people. If you're continuously infected with malaria, you develop high levels of protection, and you suffer very little for each bout of malaria. If you're in an intermediate zone, it's a little less, and if you're in a seasonal, you suffer most because your immunity doesn't last a full year before you re-encounter it. Okay, so
Dr. White.
Dr. Nicholas White is a genius with very little equipment, but with lots of intuition and lots of experience. He has enabled physicians to make the diagnosis and treatment without the use of sophisticated equipment.
Good. That's good for poor areas, correct?
Absolutely.
Yeah.
And he has my deepest respects. I've met him several times at meetings, and he's always greeted with a tremendous amount of respect from people that have heard about his work.
Now, you mentioned there are some side effects.
Yes, well, I was going to say that the latest studies on cognitive learning in small children that are repeatedly infected with cerebral malaria.
Why do you call it cerebral?
I told you, because it puts you to sleep. It attacks the tissue side of the brain.
Right, but
that's why it's called cerebral.
So that doesn't present in every infection.
The other three don't, because they don't stick.
Just with falciparum.
Just with falciparum. The others don't stick to the capillary.
In falciparum, it's a very common symptom.
Oh, I was going to tell you about the other case. I'm sorry. I did get back distracted.
I'm sorry.
There was a case here at Columbia University. I believe it was in the Department of Physiology. There was a technician who was from a malarious area and was working in the laboratory and was feeling intermittently lousy for about 6 months without a specific diagnosis. It turned out she had chronic falciparum malaria. She had partial immunity, but not enough to fight off the whole disease. She must have had some underlying immunodeficiency, which allowed this to smolder. But eventually she got acutely ill, and they found out what it was, and they cured her of malaria. But it was the first time I'd ever heard of 6 months of chronic falciparum malaria without cerebral involvement. Okay? So we use that as another case to say it can present in multiple ways, depending on how your immune system is geared to begin with. So it's complicated.
I'm looking at an interesting graph in your book.
Yes.
Page 64.
Yes.
It's plotting antibodies on Y and age in years on X.
Correct.
So
and deaths
from 8 months to 5 years,
That's
the big
right.
peak of deaths.
That's right. Because
And
that's when the
then,
IgG levels drop.
Right, and then have IgG dropping by 8
Correct.
months.
Correct.
Then we have parasite rate,
Yes.
which peaks at about 6 years. And
That's
then what does that mean, parasite rate?
If you look at 1,000 people, the highest incidence of malaria in a given area will occur around age 6 years old.
Look at that. It's young.
It's all kids.
Then we have specific antibodies, which start to go up at 8 months and peak at 10 years or so.
That's right.
And those are against the parasite or just
Lots of different antigens in the parasite, but none of those antigens protect very well.
And then anti-sporozoite antibodies, do they protect?
They do.
Those are the ones the mosquitoes give you.
No. Oh, the sporozoites. Yes,
yeah.
that's right. Antibodies against sporozoites protect against the infection. In fact, in mice, if you take irradiated sporozoites that can cause an infection but not disease, you can get 100% protection.
Why don't we use that as a vaccine?
Somebody is using this as a vaccine, as a matter of fact. His name is Dr. Stephen Hoffman. He is developing a very laborious vaccine based on extraction of sporozoites from infected mosquitoes done by hand.
Oh my gosh, it's ridiculous.
You know what? That's how desperate we are for a vaccine. But we'll get to that later.
And then these antisporozoites begin to increase at around 10 years and peak at looks like 20 years.
Yeah, that means you've been repeatedly infected until finally, if you make it to your 30s, you'll probably live to 90, unless you're eaten by a crocodile or something.
And that's the problem in these areas.
No
a
kidding.
lot of kids die.
Yes.
And, 1% die and other things happen in these areas. There are other diseases that are going to get you.
Tons of them. But the point is this, that cerebral malaria in children takes its toll in other ways also. If you live,
abilities.
Right, every time you recover, you're a little less smart than you were before. A little bit less smart. So imagine trying to stay in school. Even if you weren't sick from other things, like diarrheal diseases or upper respiratory diseases, or tuberculosis or HIV, I mean, you can go on with these things, right? You can learn at a certain rate, and that rate decreases over time.
Each infection,
so by the time you're a teenager, right?
Sad.
It's very sad. Now, ask me how many people are infected in the world.
With different types of malaria or just...
With different types of malaria.
How many are infected?
A total of around 2 billion people.
2 billion people. I heard that number the other day, yeah.
Yeah, about 2 billion.
Out of how many in the world?
That's a third of the population of the world.
Wow.
A little bit less than a third.
You know what? Is there any significant malaria research going on in the U.S.?
Tons of
it.
We've spent billions of dollars on this organism.
And do companies in the U.S. spend money on malaria?
Some.
Not as much as if it were an American disease, right?
When it is an American disease, I can tell you right now, Vince, if you're in the Army, it's an American disease because we're stationed in areas that have it.
I may be wrong, but my impression is that U.S. companies don't want to get involved because they can't make money. Is that incorrect?
Yes and no.
All right, we don't need to talk about it.
No, we don't. We were going to come back to this. I know because you've got a connection to the drug industry. Not you per se, but you know someone in the drug industry. Right. So let's come back to the clinical picture of this disease. By the time you're 20 years old and you're living in a malarious area of transmission, your immune system is highly geared to this thing, right? You end up not suffering too much from it. But like I said, if you just go into the area from a place like where we live in New Jersey, and we've never had it before, even as adults, we can die from this because sometimes our spleens enlarge so rapidly that it ruptures. You're absolutely right. And if you're in the middle of a primitive area, on safari, for instance, they could misdiagnose you before you get to a hospital.
Sure.
Or you could get to a hospital and they transfuse you, of course, and then you live from malaria, but you end up picking up
something else,
like AIDS, which used to be the case. I don't think they do that anymore because they're all screened for it. But this was a horrible problem in multiple directions. So what's the solution? Well, we thought we had the solution. We thought we had chloroquine. Chloroquine was the drug of choice in the 1960s. It was looked at as a panacea that would eliminate malaria in our lifetime. So we had not control programs for malaria. We had eradication programs. We're going to eradicate it. We're just going to get rid of it. Let's get it out of here. Let me back up a minute and just say that this has been with us since we have been a human species. And there are some famous things that are associated with this. The fever cycles were described by the ancient Greeks. In fact, Hippocrates is credited with having described 3-day fevers and 4-day fevers. Okay? And each species gives you a different pattern. It doesn't help you diagnosing the infection. It doesn't even help you to treat the infection. I always assume that they would say, you have the most serious form of malaria, we're going to treat it that way, even if you don't. You could have 2 different species of malaria in the same person, and I've seen that as a technician. I worked here, and I actually saw that twice. Amazing. You can catch malaria by transfusion, so you don't actually have to be bitten by an infected mosquito either. It can be from a blood supply that was collected, let's say, in Guatemala or someplace through Central America, and during certain crises of blood shortages, like during New Year's Eve and holiday seasons, when blood supplies are in short demand, they will buy blood from other places, and this blood may be contaminated with malaria. They don't screen for it in the blood centers like they do for other things at the blood centers, so which they could, but they don't. So you can pick it up this way too, transfusion malaria. Would malaria cross the placenta? Because if you're an infant developing, not an infant, but a fetus about to become an infant, is there a chance of catching malaria from your mother? And the answer is no. So transplacental malaria is so rare that they say it doesn't happen.
But at birth, there's a lot of bleeding.
I know there is. There's a detachment of placenta.
You could be infected then? No?
It's a theoretical possibility because the cord blood could become infected during the detachment phase, right? Because the barriers are broken. Mm-hmm. But to be honest, the blood doesn't actually make it all the way through the cord before they clip it and clip it off, and you don't have that part. So the answer is usually not. It's after you're born, when your antibodies wane during the 6-month period. After that, then you become susceptible.
Is there any component of intravenous drug use?
Yeah. During the Vietnam War and other crises like that, the veterans returning from that theater of operations, as they call it, that were addicted to drugs because of the stress factors involved in just being in combat. They brought those addictions back to this country, and they also brought their malaria back with them, and they transferred it from person to person this way. So it's had a rich history of use and abuse. And also we've had something called autochthonous malaria in the United States, introduced through airplanes in which mosquitoes actually escaped from the airplane and actually set up an infection. We had several on Long Island, and infected a Boy Scout camp, as a matter of fact. I know you're active in the Boy Scouts, Vince, and imagine taking your Boy Scouts on bivouac on Long Island to a nice beach and catching malaria. Now, which one do you think they caught? They caught the one that can last for 5 years in your liver without being detected, Plasmodium vivax. Falciparum.
Why? Why is that?
Because some people can come back into this country from visiting their relatives, let's say in the Dominican Republic or Haiti or other places. They can catch malaria because they've got antibodies against it because that's where they were from originally. They don't suffer too much. But now they've got these hypnozoite stages that can relapse. It causes a relapse, right? This person relapsed in Long Island and transmitted the malarial parasites to local mosquitoes, which then transmitted it to the Boy Scout troop. There have been incidents of malaria caught at drive-in movies. I mean, you can catch a lot of things at drive-in movies, but in this case, they were catching malaria.
But it's never
You're going to catch a movie and you come out catching malaria.
It's never become established in the mosquitoes in this country.
Oh, we used to have it. We used to have endogenous. Autochthonous malaria, and we got rid of it 2 ways.
The reservoir was us.
Well, that's not a reservoir. I mean, there are no reservoirs for this parasite. We're the only host.
People and mosquitoes.
We're the only host. But remember, we're the intermediate host. The mosquito is the definitive host. The point is that we still have anopheline mosquitoes in this country. Loads of them. We didn't get rid of malaria in this country by controlling the vector. Not per se.
We got rid of it?
You know how we got rid of it, Vince? We filled in the swamps to make more farmland.
Where were the swamps in this country? Everywhere?
Sure. Lots of places. I mean,
Yeah.
Staten Island.
We filled them in to make farmland and to build.
Or to build.
Yeah.
After the Second World
Well,
War.
there certainly are. There are still swamps, right?
Yeah, sure. Still.
Where you were born, there's swamps. And there still isn't malaria there?
No.
Why is that? The hurricane blew it away?
Because we treat every case by putting them into the hospital.
I see. And we limit the...
During the Second World War, this following statement was made. More people died on both sides in the South Pacific from malaria than from all the bullets and bombs.
Well, they weren't involved in combat, though, were they? Those malarial deaths?
Yeah.
They were?
Yeah. Yeah. So this is a big, 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 big disease.
I know that in World War I, more soldiers died of influenza than
typhus.
Combat.
And
typhus as well.
So infections play a huge role in history.
Sure,
And this is one of them that's played an enormous role.
Today, Dickson, malaria in the U.S. does not exist.
It's travelers' malaria.
Only travelers, right. There's no more endogenous or...
No, but we can reintroduce it sometimes, like, for instance...
Endemic.
Yeah, no. Oh, talk to us. Migrant workers from Mexico can bring it into California. And we've had numbers of cases transmitted near San Diego as a result of that.
They bring dengue over, too.
And they do.
And now it's in Florida.
Oh, dengue has been around for a while. And it's in
Not
Houston.
Not since the 40s in Florida.
Not since the 40s in Florida.
But
Florida is kind of an isolated peninsula.
That's a topic for TWiP.
It is. Well, we can cross over here.
Borders...
Mosquitoes don't know borders.
No. Neither do people.
Parasites. No, that's right. Except in Arizona, of course. That was a joke. That was a bad joke, too, because I'm not laughing at that joke. That's a horrible situation that's going on down there.
Oh, okay. Arizona is where they're really being nasty about this. Right? Yeah. Okay.
So the point is the clinical picture for malaria varies with your immune status. It varies with your immunogenetics.
With the species of malaria?
With the geographic region.
Yeah.
So malaria is definable in terms of the host and the parasite and the environment. And there's so much variety here that it's impossible to generalize. The chapter we wrote on malaria is a general chapter.
Yes.
But there are entire books written on this subject.
Of course.
And they still don't cover the subject. Okay, so this latest issue of Science, which is my pick of the week, is read all of the stuff on malaria and realize that in the end, we don't have any effective drugs. We don't have a single vaccine. We impregnate mosquito bed netting with insecticides in hopes that people can sleep underneath them so that the night-biting mosquitoes won't get to you. We can reduce the incidence of malaria by about 50% under optimal conditions using bed nets. This was championed, by the way, by Jeffrey Sachs at Columbia University's Earth Institute. He's the director of our Earth Institute, and I think he's done a fabulous job of making people aware of the fact that malaria is an intractable disease that requires heroic efforts at every level, including altering the environment, clearing the swamps, getting rid of mosquitoes, trying to get rid of people's habits that enable them to catch malaria during their waking hours and sleeping hours. It's a difficult, difficult problem. It's never going to go away, Vince.
No? Even
Never.
with good vaccines and drugs?
You know when it's going to go away? When we become extinct.
That's
the
sobering.
only possible way to get rid of malaria.
We can minimize
is to
its
extinct
effect,
people,
right?
because then you'll eliminate the intermediate host.
But we can reduce significantly the incidence, right?
Well, remember what I said about tropical diseases. The best cure for tropical diseases is winter.
Winter.
So, even though they keep
But
saying
Dickson,
that.
There's a huge effort. You're saying it's not worth it?
Ask Stephen Hoffman how he feels about this, or ask Bob Grodz, one of our co-authors on this book. He's a mosquito geneticist and a big expert in malaria, and he'll say we can control it, but we can't eradicate it.
All right, that's fine. I think control is useful because you can save a lot.
You can. But what happens when the control program for malaria is superseded by the control program for dengue, or the control program for HIV, or the control program for filariasis, or the control program for war? See, war is a big disruptor. Civil unrest and war is what results in the spread of these infections beyond the control of anybody. So you're at the risk of nature at that point.
Dickson, can we fill in the swamps in the tropical regions and get rid of them? No?
Absolutely impossible.
Too much?
Impossible. They've never been successful at doing that.
They've
not
tried?
into tropics. No, they don't even try. In fact, what they do in the tropics is to generate more water by damming up rivers. And when you do that, you're creating more malaria breeding areas. So it's everywhere you look, there are huge challenges for the technological gifted communities to try to come to the aid of those that can't help themselves.
It's very sobering, Dickson.
Huge.
It sounds
and we're not
to me,
done yet. We're not done discussing malaria, but we probably are for this session.
We need one more for drugs and vaccines.
We do.
To talk about what's
we do. Yeah, we
being
do.
worked
And for
on.
that, I think we should get a guest on. We should get Charles Knersch, one of our co-authors on this book also, and he's a well-respected expert on these two subjects.
Both.
Of vaccines.
He can do both vaccines and drugs?
He can do both.
All right. You think he'd Skype in with us?
I might even
Where
come
is
visit.
he? Where is he?
He spends half of his time at Pfizer, Inc.
Where's that?
I think they're going to move, unfortunately, but they're now on 43rd Street. And
He's in the city.
Yeah, he's in New York.
Well, maybe he will come up one day for us.
I know he will.
Okay, that would be the easiest.
Especially if he listens to this podcast, he will.
Can you make the
I can make the introductions.
required?
Absolutely. We'll offer him a pizza.
Sure.
Everybody shows up for pizza,
We'll
right?
sit around the desk, and he can tell us.
He would love to talk about this
Great.
because he's involved in the Millennium Development Goals, and this malaria fits well within those goals.
Excellent.
All right.
Let's read a few emails.
Dynamite.
This first one is from Sophie.
Okay.
Hi, Dick and Vincent. I still love both of your podcasts and was very pleased when Dick referred to Claudius, as I love the books about him. You referred to Claudius?
I did. Claudius. Remember the series on television also. One of the episodes involves the opening of the port of Ostia.
That's right.
And they cured the malaria in the local area by filling in the swamp
Yes,
to develop
exactly.
that port.
The malaria-themed podcast made me realize that the historical part of parasitism is so interesting. I'm talking about the really old stuff, and although it is very difficult to say much about this, I would really like to know more about parasitology and their influence on history.
Aha.
You don't probably know much about that, do you, Dick?
I know something about it, but I know some of the experts in that field.
Yeah.
Robert Desowitz writes a lot about those.
Well, we should get him on, too. Where's he?
He's now retired. I think he lives in Hawaii, if I'm not mistaken.
Hawaii.
Yeah.
We're not going to get him to visit.
No, I don't think we will, actually.
Well, we'll try and do some... Well, you give us history at every parasite.
Try to.
Try to. You do it.
You have to know where they start.
Of course. I agree, even with viruses.
Yeah, because we don't want to repeat the mistakes of history, do we?
But
And
we
yet
always do,
we
Dickson.
seem to manage to...
Dixon War is a mistake of history.
We are so good at repeating all of the historic errors and not so great at repeating the historic successes.
Human species, Dixon,
I don't get it.
does wonderful stuff, and it screws up all the time.
You know what? I know why, too. Because we're at 1 to 4% Neanderthal genes.
No.
We just learned that.
I don't think you can blame that. You're in control of what you do.
You are. Yeah.
This is from Aaron.
Hey, Aaron.
Aaron I met this week in Gainesville.
Cool.
Dear Vincent and Dick, I have been fervently enjoying your podcast since I learned about them a few months ago from Rich Condit. I'm a grad student at the University of Florida, and I'm on a training grant he's involved with. I've been trying my best to catch up with your TWiP episodes, and I was delighted when you started TWiP. I study a protozoan parasite called Babesia bovis, which I bet Dick is aware of.
Sure, it's a malaria-like parasite transmitted by ticks.
Believe me, most people are not.
It's
Shipping
a
fever?
huge- No. That's Brucella abortus.
Brucella.
That's a bacteria.
Sorry.
This-
Babesia was the first shown to be transmitted by a vector, right?
That's correct, by Theobald Smith.
Yeah, you recounted that story. I
did.
only know it because you told us.
The Lone
Dixon.
Star tick transmits it in cattle.
Okay. Well, it's funny. We were at a meeting just a few days ago, and
Humans can get a similar disease.
there were 5 graduate students, and she said, I work on Babesia, and all of the other 4 said, what's that?
Yeah, right. You'd know it if you didn't have a spleen. If you were splenectomized as a child,
Yes.
and you went out to, let's say, Shelter Island or Nantucket or Block Island, where there are lots of deer, and the deer ticks are plentiful, and Babesia is also plentiful, you don't have a spleen, you die. There's no drug for this.
We'll do a session on Babesia sometime. Do you know anything about it?
I know a little about it. I wouldn't consider myself an expert
Okay.
on that one. But I do know that your spleen plays a huge role in the protection against Babesia. So why doesn't it work against malaria?
They're not conserved enough, right?
Right.
The
They're totally
antigens.
different in
Totally
terms
different.
of antigenic structures.
I just listened to the TWiP episode in which Dr. Condit tells you about our seminar program, where students get to present the speaker's papers to them after the talk. Wouldn't you know, I am one of the lucky students who gets to present to you. Of course, I did not realize this at the time I was assigned to you. I was just annoyed that most of the speakers were virologists, not a single parasitologist. How surprising.
Yeah, right.
And terrified because I know so little about virology. Presently, I feel slightly better about the virology aspect after listening to so many of your informative and entertaining podcasts. However, you have become somewhat of a celebrity to me, but don't yet know I exist, which I was beginning to feel a little weird about. Hence this email. I'm very excited to meet you, and I think you should bring Dick along. I will take him fishing in my canoe.
Oh, I missed out on a beautiful opportunity there. Vince, you have to go back.
Also, I have a suggestion for a podcast topic which could actually be covered on either TWiV or TWiP.
Okay.
The particular aspect of Babesia bovis that I study is its ability to undergo rapid antigenic variation, which I'm sure you know is not unique to this organism.
Right.
I think people would be interested to hear about antigenic variation and how it allows pathogens to evade the host immune response.
Sure.
Also, could you talk about antigenic shift and drift and the difference between these three events? Sorry if you've already covered this topic. Like I said, I haven't quite caught up yet. And trypanosomes do that, as well as influenza virus, of course.
Exactly.
Like Dr. Condit, I enjoy your podcast most while on my daily bicycle commute. I truly appreciate the opportunity you've given me to learn something during this otherwise uneventful part of my day. My other favorite podcast is This American Life. If you haven't, you've heard that?
There's something like that on television also.
If you haven't heard it, please give it a listen. In fact, there is an episode, number 404, called Behind Enemy Lines, that has 2 stories about parasites, including one about a man who purposefully acquires hookworm by stomping around in tropical third world country latrines to ease his allergies and asthma. Sorry for all the rambling. Thanks again, and I very much look forward to meeting you. Cheers, Aaron. P.S. One of my cats is chronically infected with tapeworms, despite my best efforts to eradicate them. I find lots of little proglottids in her favorite sleeping spots, and sometimes I find 2 to 4 inch long flat crusty worm segments that look like rice noodles. I'd be happy to save one for you.
Only another parasitologist can say, oh, please do.
Anonymous writes, I'm a little behind on both TWiV and TWiP, but as I was listening to the Trichinella TWiP while collating appendices, I had a thought. I have heard over the years that the lack of parasites in our society is related to the high incidence of allergies and autoimmune disease. I will fully admit this may be a stupid question. When looking into making vaccines for parasites, as Dick mentioned has been done, has it ever been considered as a way to stimulate the immune response without causing any disease to help prevent or treat allergies and autoimmune diseases? Just thought it was an interesting idea.
It is a good idea. But I would caution in that one, because when you stimulate immunity by giving an antigen, you're stimulating it throughout the entire body. And most of these allergic responses that you suffer from, like Crohn's disease or inflammatory bowel disease, are targeted immune responses to tissue antigens in a specific location. So in order to prevent that from happening, I would think that if you had some way of tethering the antigens onto an insoluble matrix and implanting that
in the right place,
you could direct the immune response to that little part of wherever they are, rather than throughout the entire body, and then therefore avoid the damaging effects of, let's say, Crohn's. And I think there are people working in this area right now to find out which antigens are at work that the host immune response mistakes for the parasite that it confuses with itself. Remember, not everybody gets all these things, right? This is got to be a subset of people with a specific immunogenetic pattern, which there's something probably missing, some element of recognition that's missing that prevents them from making antibodies against themselves, which we have that they don't have. And so in order to find that out, I think you'd have to do a complete human genome, or at least of the immune response genes, and see where the differences lie. Complicated stuff, though. Very complicated.
That's a good idea, right?
It is a great idea. Absolutely.
It's
no
not
money.
It's not a stupid question.
It's not a stupid question. The only problem with it is try to formulate that into a grant and submit it to NIH, and I can guarantee that it won't be funded. It will not be funded.
All right. We have another email from Anonymous. I
Two.
listen.
They must be brothers.
No, they just don't want us to tell who they are.
Right.
I listen to at least a dozen podcasts regularly, and sometimes I don't have time for every episode, but TWiP and TWiV are two that I never skip.
Great.
I think that's great.
I do, too.
I'm always entertained and always learn something. It's not at all related to my present occupation, electrical engineer working on rockets. Wow.
Uh-huh.
But maybe that's why it's especially interesting, because it's so different. Question. I'd be interested if you could cover diseases that we can get from our pets, as I have several dogs and a couple of little kids.
Yep.
I wonder what kinds of scary parasites you can describe that can help keep me up at night worrying. At least we are in Arizona, so we don't have many fleas or ticks around. I guess it gets too hot?
No, it's not too hot for fleas and ticks. No, not really.
Why aren't there so many?
Probably because there are very few people and very few pets. But if you go to some areas of Arizona, you can find a lot of them. In fact, let me recommend to this listener a television show on the Discovery Channel called Monsters Inside Us. I happen to be the technical advisor to that show, and I can tell you that there are episodes coming up that will deal with parasites that are spread from your pets to yourself, and there are ways of preventing this too.
Cool. Very good. That's a Discovery Channel program?
Yep. Monsters Inside Us.
Tip. GiantMicrobes.com. Check out this website. The cool stuffed bugs, germs, viruses, etc. Stuffed bears are entirely overrepresented in the stuffed toy world. Yeah, we've talked about this before. Have you seen this?
Yeah, absolutely.
They have some parasites here, I believe.
They do.
Let's see what we have. Amoeba, algae, bacteria.
Amazing.
I'm looking for parasites. They have a bookworm.
A bookworm.
A lot of viruses, chlamydia.
Love it.
Bacteria.
By the way, my name means apple trees in French.
It does.
So I used to say that I was the only apple that studies worms.
Look, they have a flea.
That's a vector.
That's funny. I didn't see.
Fleas are not just vectors for plague, by the way. They also transmit tapeworms.
Is that right?
Yep.
Wow.
They do.
Leishmania.
There it is.
Leishmania tropica.
Excellent.
There you go.
Hey, I like it.
They even give it a little eye.
That's not an eye. It's the nucleus, Vince.
I don't know.
It's a
looks like
eukaryotic parasite.
It says here, one bite from a tropical sandfly can ruin your complexion.
That's true.
Is that true?
Yeah.
Oh, look, malaria.
Aha!
There it is. It's got an eye as well. It's not an eye, Vince.
Not an eye, Vince. That's
What
right.
is it?
No, that's a nucleus.
Listen to what it says here. The tropics have coconuts, soft beaches, clear water, shiny fish, colorful birds, steel drums, umbrella drinks, and malaria. Only $7.95.
Trouble in paradise.
Sleeping sickness.
Oh, trypanosomes.
Got a trypanosome.
Look at that. Does that have an eye also, Vince?
I don't see it.
It should. In fact, it should have two eyes.
Are you tired, working too hard, feeling a bit cranky? Do you think you might have sleeping sickness? This little fellow will sing you a lullaby you'll never forget. And finally, West Nile virus is a mask. This is a bit crazy. This has eyes, Dickson. It's not supposed to have eyes.
Of course not.
All right, check Giant Microbes out. P.S. I need TWiP to be more frequent, please. Thanks for all the time you guys put into this. It's very much appreciated. P.P.S. If you ever change your tagline at the end, it could be another TWiP is in your brain.
Arg.
Now, we have 3 emails sent about the same story.
Huh.
I don't know if you heard about this, Dickson. We have from Duncan, Vincent, and Michael.
Okay.
Duncan says... here's the link to the story. Health authorities are warning of the dangers of eating slugs as a Sydney man battles a rare form of meningitis. The 21-year-old caught rat lungworm disease after he ate a slug as a dare.
Angiostrongyliosis.
So what's the shtick here, Dickson?
The shtick is that
he ate the slug?
Slugs and some organisms like slugs.
It's not a parasite, is it?
The slug isn't a parasite,
Okay.
but it's harboring a stage of this parasite called Angiostrongylus.
Ah, the lungworm.
Yeah, Angiostrongylus cantonensis.
So it's a rat lungworm?
It is.
It lives in a slug?
Only as an intermediate host.
And
it lives in the rat as the definitive host.
Does it cause disease in the rat?
Oh, yeah.
Good.
Yeah, it does in us, too.
Bad lung disease?
Well, in the rat, it's in the lungs, but in the humans, it gets to an aberrant site, which is in the meninges of the brain.
Yes, can cause fatal swelling of the brain and spinal cord.
Correct.
It says your immune system gets rid of it.
I wouldn't go that far. The worm. What happens is the worm dies because it's in the wrong place.
Yeah.
And if it dies, in parasitology terms, when it dies, it calcifies.
He says it can also be caught from raw vegetables or fruit that have not been washed properly. Yes?
Because they have slugs on them that you don't see.
Okay.
That's right.
So you don't know much about lungworms, right?
A little bit.
We're going to talk about it another time?
It's in the book.
All right. So that's from Duncan, who's in Australia.
It's called a zoonosis. That's a zoonosis, by the way.
So if you don't eat it on a dare, as this guy did, who's in critical condition, by the way, how else would you acquire it? By vegetables?
Yep. By accident.
So Vincent is from Cleveland.
Okay.
He said, I'm sure someone has sent in this article, but he brings it to us. Keep up the wonderfully good work on both podcasts.
Glad you like it.
Like your name. And then Michael sent it as well.
Okay.
All right, thanks, guys. Another Michael writes, since we can't get enough of TWiP, I have started a Facebook group on parasites and parasitology.
Great.
Feel free to cross-post on it and spread the word. I have linked this website to the group, and perhaps you would do the same.
How marvelous. Sure, we'd be glad to.
I think we're both on that group, you and I.
Yep.
Thanks, Michael.
This is where TWiP becomes viral.
That's right, Dr. Michael. John writes, I love both TWiV and TWiP, but I need more frequent TWiP podcasts. Too much waiting gives me digestional problems. So due to my failing health, I need more frequent TWiP productions, much more if possible. Of course, I don't have a doctor's note, but I am working to get into the microbiology PhD program at the University of Florida.
Oh.
And I can't handle the extra stress. Hook us up, guys. We need our fix. Thanks for the awesome shows.
We'll try.
I don't know which University of Florida. If it was Gainesville, I was just there, John.
Exactly.
And the last one is from Nora. I'm an avid listener to TWiV, and I just recently am catching up on TWiP. I work in the biotech field, formerly in clinical viral production and now antibody production.
Wow.
I specialize in largish cell-based production, I suppose. Well, virology will always be close to my heart. Anyway, I have a couple of comments for TWiP. I've only listened to the first couple of episodes, so hopefully no other listeners have beat me to this. On the first podcast, you said that there are no parasites larger than insects. I believe I have thought up
Who said that?
an exception.
Wait a minute.
I think it was you, Dickson.
I didn't say that.
The cuckoo bird would be a parasite.
Oh, I see what you mean. I see what she's talking about.
Wikipedia lists it as a brood parasite. I would love to be the first listener to have thought of this, as you have a very intelligent lead listenership. I don't think the cuckoo... Did someone mention that earlier?
No, but what the cuckoo bird does is lay their eggs in other birds' nests and forces the other bird to raise its young.
Them,
and the cuckoo bird young kicks out the other species.
So is that parasitic?
No.
Why?
What is it parasitizing? It's actually
doesn't live within,
displacing.
So parasites live within other organisms?
Yeah. That's right.
In the second podcast, you discussed ivermectin.
Yes.
Just an interesting side note, this is also used extensively for horses. It is part of the wormer rotation used against roundworms, bots, etc.
Correct.
My bachelor's degree is in equine science.
Nice.
Cool.
Nice.
I wonder if you wouldn't do an episode on tuberculosis. I find this disease very interesting, and it is making a worldwide comeback. Thank you.
Read this last issue of Science, the May 14th issue of Science, which has a whole section on tuberculosis. And
if we ever start TWiB,
right,
we will have an expert, and
yep,
we'll do that. But tuberculosis is a mycobacteria.
Yes, it is. And an obligate intracellular parasite.
Yes, but it's not a eukaryotic parasite, which is the topic of TWiP.
This is exactly right.
Well,
so we have one more episode to go on malaria
yes.
before we move on to toxoplasmosis.
And whether we do the next episode of malaria depends on Dr. Knersch's schedule.
That's
you should contact him and tell him.
I'm going to make every effort to do that
in the next 2 weeks.
ASAP.
All right. You have been listening to TWiP, of course, and we'd like you to subscribe to us in either iTunes at the Zune Marketplace, and if you can't do that, well, you can always listen it to the on the website. Oh, what was I going to say?
I don't know, Vince. Perhaps you were going to say...
What is our website?
Our website.
Microworld.org/TWiP.
That's
you can
right.
play it right there, download it, and we have show notes as well. If you like it, tell others about it, and leave reviews in iTunes. That helps us stay on the front page, so more people will discover us.
Indeed.
So you can find TWiP at microbeworld.org/TWiP, sciencepodcasters.org, or promednetwork.com. And these are all places where you can find other science podcasts as well. As always, send us your questions and comments, twip@twiv.tv. Thank you, Dickson.
You're welcome, Vince.
I was educated as always.
You ask great questions. No, you do.
I'm very interested. I'm curious.
You are. That's why you're a great scientist, Vince.
Well, I don't know about that, Dickson.
I do.
But I love learning about viruses and eukaryotic parasites.
Well, there used to be a hockey announcing team on the Rangers.
Yes.
Right? And one of them always said to the other, he says, knowing you is like going to college.
Wow.
You know, Vince, knowing you is like going to college.
Well, you too. I agree. I'm learning a lot.
So that's the idea
Dickson,
of sharing news.
Next on TWiV, we need to do a Virology 101.
Right.
Now that my course is done, I'm ready.
Okay.
Let's try and do that sometime.
Let me ask the stupid questions.
Yeah, we take turns.
You didn't ask stupid questions, but in TWiV, I can ask some really stupid questions.
Stupid questions on this one.
No.
You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon. Another TWiP is parasitic.